Now benzodiazepines binding site is the alpha 1 and GABA subunits. Benzodiazepines induce a conformational change in the GABA A receptors, allowing GABA to bind. This alteration in turn induces a conformational change in the GABA A receptors chloride channel that hyperpolarizes the cells and account for GABA's inhibitory effect through the central nervous system. Now GABA is obviously a transmembrane protein. Now this is a chart on how the benzodiazepine is going to act. So it will bind on the site. We can see that there is a BZD site, benzodiazepine binding site. This is basically the top view if you're viewing the GABA molecule from above. So that is alpha 1 and gamma 2. So that is basically where the benzodiazepine will bind. And the binding will trigger influx of chloride ions leading to hyperpolarization of the membrane, and hyperpolarization will increase the firing of neurons. Now the increase of decrease of firing of neurons. The decrease in firing of neurons will also decrease the spinal cord activity, causing muscle relaxation, will also decrease the cerebral cortex activity, causing a decrease in seizures and hypnotic effect, and the decreased firing of neurons will also then lead a decrease in fear, decrease in panic and phobia, will also act as the anxiolytic through the decrease in CSCT circuit activity, and that will also then cause the adverse effects that are seen in the benzodiazepines. Anterograde amnesia, convulsion, ataxia, slurred speech, weakness. It can also then cause dependence, tolerance, and overdose, which will cause respiratory depression, though it is very rare, but it might also cause respiratory depression. Effects of long-term use of benzodiazepines. Long-term use of benzodiazepines can have the following effects: daytime drowsiness, decreased reaction time, increased risk of accidents, memory impairment in older adults, minor symptoms such as headache, tremor, sweating, physiological and psychological dependence, reduced sleep quality, and the overdose causes difficulty breathing, blurred vision, severe weakness, then confusion, disorientation, dizziness, coordination issues, stupor, and coma. Now, what are the unmet need and limitation of current treatment options? Now, the unmet need is that we need some more effective, rapidly acting management and better tolerated medications. We need early identification of non-response, effective treatment for refractory disorders, prevention of relapse, and promotion of resilience and long-lasting response. Increase in the risk of suicidal ideation and behavior seen in patients with SSRIs, SNRIs, or a TCA. SSRIs also cause a lot of GI symptoms and increased risk of falls, osteoporotic fractures in patients age 50 or older. And TCAs cause significant cardiac toxicity and fatality. Benzodiazepines, again, sedation, fatigue, ataxia, slurred speech, memory impairment, weakness, increased risk of motor vehicle accidents is seen. We tell the patients to not drive if they are on a benzo. Caution and careful monitoring is indicated when prescribing benzodiazepines to elderly patients, because it might increase the risk of fall and injury, those with pre-existing cognitive impairment or those with a history of substance use disorder. Now let's move to the molecule etifoxine. Now what is etifoxine? Etifoxine is an anxiolytic and an anticonvulsant drug of the benzodiazepine family. The anxiolytic-like property of this non-benzodiazepine compound have been documented in both animals and humans. Etifoxine is devoid of benzodiazepine-related side effects such as sedation, amnesia, myorelaxation, tolerance, and dependence, and thus etifoxine preserves psychomotor attention and memory performances. This is what the recent research has shown us. Etifoxine is approved in India and 53 other countries such as Argentina, Bulgaria, Chile, France, Luxembourg, and other countries such as Thailand and Ukraine. And in India, it was approved by the DCGI, the Drug Controlling General of India, on 13th of December 2023 for generalized anxiety disorder with somatic symptoms. Now, what are the therapeutic indications of etifoxine? It is indicated for psychosomatic manifestation of anxiety. Mechanism, it is obviously a non-benzoanxiolytic and have dual mechanisms. of action on the GABAergic transmission. So it is going to act on the mitochondria as well as the GABA A receptor. Direct potentiation of GABA A receptor activation through a site different from the classical benzodiazepine binding motif, and it also modulates GABA A receptors via stimulation of the neurosteroid production through the mitochondria. Direct potentiation of GABA A receptor, it binds to the GABA A receptor on beta subunit with a marked preference for beta 2 and beta 3. This binding leads to a positive allosteric modulation of chloride currents resulting from the opening of GABA A RS receptor channel. So it is not going to bind to the same part wherein the benzo is binding. It has a different binding site. Modulation of GABA A receptor via stimulation of neurosteroid production. So it also binds to the mitochondria TSPO. Binding of etifoxine on TSPO favors the entry of cholesterol into the mitochondria and its conversion by several enzymes to potent endogenous anxiolytic called as alloperoganolone. Anxiolysis is then achieved by a neurosteroid-based potentiation of GABA A receptor function. Together, the direct and indirect action of etifoxine on GABA A receptor lead to synergistic and long-lasting anxiolytic effect, at least in animal models. So here we can see that it has a dual mechanism. It is also acting on the TSPO of mitochondria, which is causing the other other way of action, and one is directly through the GABA. Now TSPO, which is basically the translocator protein, formerly known as peripheral benzodiazepine receptor, located on the outer mitochondrial membrane. TSPO interacts with mitochondrial permeability transition pore located in the outer mitochondrial membrane and adenine nucleotide translocator ANT on the inner mitochondrial membrane. Now let's look at benzodiazepine versus etifoxine. Now benzodiazepine is binding to the alpha and gamma subunits of the GABA A receptor, whereas this one etifoxine is binding to the beta 2 beta 3 subunits, leading to a positive allosteric modulation of chloride currents resulting in the opening of GABA A receptor. It also induces a conformational change in the GABA A receptor's chloride channel that hyperpolarizes the cells, and it modulates GABA A receptor via stimulation of the neurosteroidal production. Alpha subunit influences the pharmacological properties of agent binding to it, which causes sedation, relaxation, and amnesia. Etifoxine is devoid of benzodiazepine related side effects such as sedation, amnesia, myorelaxation, and tolerance of and dependence. Here there is a comparison of mechanism. Advantages of etifoxine over benzodiazepines. Etifoxine, a non-benzodiazepine drug belonging to the benzodiazepine class, has a dual mechanism of action on the GABAergic transmission. The tolerability profile of etifoxine is better than benzodiazepines, notably because of a lack of effect on memory and vigilance. In addition, treatment cessation does not cause drug dependence, withdrawal, or rebound anxiety. Different binding sites for etifoxine and benzodiazepine. This may explain the lower adverse effects with etifoxine compared to benzodiazepines. Pharmacokinetics, it takes around 2 to 3 hours to reach maximum concentration. Metabolized rapidly in the liver, crosses placental barrier. Half-life is around 6 hours, and it is mainly excreted in urine as metabolites and also excreted in the bile. Small amounts are excreted in unchanged forms, and it is rapidly absorbed through the GI tract. Clinical studies, we will basically go through 6 clinical studies. We'll have an overview of it. Now it is etifoxine versus lorazepam in healthy adult subjects, etifoxine versus lorazepam in healthy elderly subjects, etifoxine plus alprazolam in the patients of GAD, etifoxine versus clonazepam in anxiety disorders, etifoxine versus alprazolam in adjustment disorders with anxiety, and etifoxine versus lorazepam in adjustment disorder with anxiety. So study 1, so we'll go through the 6 studies. Study 1 is the comparison of sedatic and amnesic effect of etifoxine and lorazepam in healthy subjects. Now there is 4 groups: single dose of etifoxine, 100 mg, 50 mg, 2 mg, and a placebo. The endpoints are choice reaction time, then barrage test for visual attention, immediate and delayed free recall of pictures, VAS for sedation and mood, and adverse effects. So we basically took healthy participants in the age group of 18 to 35 and in good physical health. The time of assessment was chosen on the basis of pharmacokinetic and parameters of the drug. We can see the choice reaction time, that is roughly to explain it as the time taken from the stimulus to the desired effect. The choice reaction time of lorazepam 2 mg was somewhere around 3.8 ms, and etifoxine 50 mg and etifoxine 100 mg had similarish choice reaction times, but it were much less than the lorazepam. Then in vigilance test also it has been seen that lorazepam impaired significant performance on barrage test as compared to etifoxine 50 mg and placebo. The number of errors were also higher under the lorazepam than placebo. Then memory test was also done and treatment effect was highly significant. Subjects under lorazepam 2 mg had a significant lower score on immediate and delayed recall than did subjects of the other three groups. On the visual analog scale, at T2, subjects under lorazepam felt more tired and more woozy than the subjects under etifoxine 50 mg and the placebo group. More drowsy and more clumsy in comparison to etifoxine 50 and 100 mg than placebo. Conclusion: studies show vigilance, psychomotor performance and free recall were significantly impaired by lorazepam. Neither dosage of etifoxine 50-100 produced more effects. Study also suggests that 50 and 100 mg single dose of etifoxine do not induce amnesia and sedation as compared to lorazepam over here. Now, this is basically alertness or cognitive functions in the elderly. Again, comparing it with lorazepam, etifoxine 100 mg was given, etifoxine 50 mg was given, then there was a washout period, lorazepam 2 mg was given, lorazepam 2 was given 1 mg and then placebo, and every time there is a washout period. Then lorazepam 1 mg washout period, placebo, etifoxine 50 mg, placebo washout period, etifoxine 50 mg, lorazepam 1 mg. So there has been a washout period of 14 days to 1 month. Cantab reaction time compared to placebo, single dose of 100 mg of etifoxine had no deleterious effect on alertness as evidenced by a non-significant difference in reaction time. 2. Cantab RTI test. On the other hand, as a positive control as compared to placebo, lorazepam significantly increased the reaction time. Secondary endpoints: the two neuropsychological tests used to evaluate the attention showed that a single 100 mg dose of etifoxine had no deleterious effect on attention. The Cantab rapid visual information processing and the Stroop test gave comparable results with etifoxine and placebo. This is basically the graph explaining the previous conclusions. And secondary endpoints: pair association learning, ray, or audition verbal learning test, spatial working memory test. These were used basically like ray audition verbal learning test is basically a test of 15 words which are given to the patient to memorize. Then paired association learning, you have to pair two non-similar words. And compared to placebo, etifoxine caused no memory disorder, neither on visuospatial, verbal, nor on working memory. Lorazepam significantly impaired alertness, attention, and both working and verbal memories. This is the chart which is basically summarizing it. And safety total: 87 adverse events were reported in 24 hours, etifoxine, placebo, and lorazepam. Conclusion: the Etilance study showed single administration of 100 mg dose of etifoxine has no effect on alertness, did not impair cognitive function. The absence of evidence about long-term cognitive disorders, etifoxine an alternative to classic benzodiazepines, especially in elder subjects for anxiolytic treatment. This is the third study. It is basically alprazolam and etifoxine in GAD with somatic symptoms. Etifoxine 150 mg per day was given in 3 divided doses and alprazolam 1.5 mg in 3 divided doses. We had healthy volunteers again from 18 to 35 age group, and HAM-A score was taken, and endpoint was HAM-A as primary efficacy evaluator, then CGI-S and CGI-I and PGI items as secondary efficacy evaluation was done. Results: primary efficacy evaluation changing from baseline and Hamilton rating HAM-A total score at day 28. The reduction in HAM-A total score from baseline to day 28 was comparable between test arm and comparator arm. The mean difference of test versus comparator was minus 0.18, and statistical significance was also observed within each arm from baseline to day 28. Secondary efficacy evaluation from baseline in HAM-A psychic subdivision at day 7, day 14 and day 28. Again, a reduction was found and were comparable between test arm and comparator arm. And statistical significance was established from from baseline to day 7, day 14 and day 28. Again, there was seen a reduction in the somatic subscore at day 7, day 14 and day 28. And in the clinical global impression severity scale score at day 7, 14 and 28 compared to baseline, it was seen a reduction. Here we can see that the reduction is much higher on day 7, day 14 and day 28 with etifoxine than alprazolam. Then this is the global impression improvement scale. On that we again see that the improvement is much higher. The generalized safety was also found to be much better with etifoxine. Conclusion: etifoxine 50 mg capsule has been found to be non-inferior in comparison to alprazolam 0.5 mg tablet in the treatment of adult patients with generalized anxiety disorder with somatic symptoms. Overall, both the treatment were well tolerated. This is the fourth study. It is a non-inferior study than clonazepam in treatment of anxiety disorder. Etifoxine 150 mg per day in 3 divided doses and clonazepam 1 mg per day in 3 daily divided doses. HAM-A was taken at 12 weeks, 24 weeks. Clinical improvement scale was used and adverse events were noted. The population was 18 to 60 years. Analysis of anxiety symptoms. Estimated difference in means between etifoxine and clonazepam was seen. At 12 weeks, 3.6 points decrease was found compared to clonazepam in favor of etifoxine. At 24 weeks, it was minus 3.55 in favor of etifoxine, and etifoxine shows to be superior to clonazepam at 24 weeks. Analysis of clinical improvement. The mean for both groups in the CGI-I at 12 weeks was about 1.5, which represents an improvement between the categories of much better and moderately better. Mean at 12 weeks for etifoxine was 1.39, for clonazepam was 1.62, indicating a perception of greater improvement among patients treated with etifoxine. However, this difference of 0.23, which has a SMD of 0.306, implies a 95% confidence interval of minus 0.21 and 0.83. That includes the 0 but does not cross the margins of 0.31 SMD. So non-inferiority can be declared for clinical improvement. Conclusion: this study analyzes non-inferiority on effectiveness and adverse effects of etifoxine versus clonazepam and was longest duration study that compares etifoxine with another benzodiazepines with a follow-up at 24 weeks. The fifth study is alprazolam, etifoxine versus alprazolam for the treatment of adjustment disorder with anxiety. Again, etifoxine 150 mg was given in 3 divided doses and alprazolam 1.5 mg in 3 divided doses. The endpoints were HAM-A and self-reportment for assessment of adjustment disorders and adverse effects. The results were basically improvement on anxiety symptoms, mean decrease in the HAM-A total score. On day 7, etifoxine was at 51.2% and alprazolam was 58.7%, and on day 28, etifoxine was 72.5% improvement and alprazolam was 79.7%. The benefits of treatment appeared from the first week with a mean decrease in the HAM-A score of and in the etifoxine and alprazolam groups respectively. 1 week after treatment discontinuation, HAM-A scores of etifoxine group continued to decrease, whereas alprazolam group increased. Adjusted mean difference in the HAM-A score of minus 0.93 in favor of etifoxine demonstrated non-inferiority of etifoxine compared with alprazolam at day 35. Conclusion: the current data supports the efficacy and safety of etifoxine in the treatment of anxiety disorders, adjustment disorders with anxiety, while benzodiazepines such as alprazolam may be reasonable to consider. Etifoxine was associated with fewer CNS related adverse effects and no rebound effect after treatment discontinuation, and therefore is an important alternative. The sixth and the last trial that we are going to see is a non-inferior trial to lorazepam in treatment of adjustment disorder with anxiety. Again, etifoxine in 3 divided doses, 150 mg per day, and lorazepam 2 mg per day in 3 daily divided doses. HAM-A score was taken at 28 days, HAM-A score was taken at 7 days, CGI was taken, and social adjustment scale self-reported was taken. Patients were from 18 to 65 years. At day 28, decrease from baseline was seen as 11.4 in etifoxine group and 12.2 in lorazepam group. The mean difference was minus 0.56. Analysis of HAM-A scores concluded the non-inferiority of etifoxine compared to lorazepam. The clinical global impression: there was improvement in both groups on day 28. Severity of disease was decreased with etifoxine as with lorazepam. Clinical improvement was significantly higher in etifoxine group with regard to the number of patients markedly improved. Efficacy index: the percentage of patients having a marked therapeutic effect without side effects was superior in the etifoxine group. Conclusion: in this study, etifoxine was at least as effective as on anxiety as lorazepam at usual doses 1 month. Moreover, after 1 month of treatment, a significant higher percentage of etifoxine recipients experienced a marked decrease in anxiety without side effects. With regard to the efficacy results and the lower incidence of anxiety rebound after the end of the treatment compared to lorazepam, these results suggest that etifoxine could be an interesting alternative therapy to benzodiazepines. Now we'll move to etifoxine's dosage forms, duration of treatment. So it comes in a capsule form of 50 mg. Dosage is usually 3 to 4 capsules taken a day, taken as 2 to 3 divided doses. Duration of treatment is few days to few weeks depending on the clinician's need. There is also use in special populations. If we see, if we take the pregnancy and breastfeeding population, considering the available data, it is preferable to avoid using etifoxine during pregnancy as a precautionary measure. Whatever as the data will come, we might consider using them in pregnancy and breastfeeding population. Hepatic impairment, in that etifoxine is contraindicated in severely impaired liver functions, contraindicated in severely impaired liver and renal functions. Now the basic list of contraindication is hypersensitivity to the active ingredient or any other of the molecules, states of shocks, severely impaired liver or renal function, myasthenia, patients who have had severe cases of hepatitis or cytolytic hepatitis during previous treatments with etifoxine, and patients who have had severe dermatological reactions including DES syndrome, SJS, and dermatitis generalized during previous treatments with etifoxine. Drug interactions: inadvisable combinations, alcohol increases the sedative effects of these substances. Impaired alertness may make vehicle driving in machinery operation dangerous. Avoid alcoholic drinks and medications containing alcohol. Combinations to be considered: It can be considered with other CNS depressants. It can be considered with morphine derivatives, sedative antidepressants, central antihypertensives, and a long list of other medications. What are the key highlights of today's seminar? The total number of individuals affected by anxiety increased substantially between the 1990s and 2019. Now the global reported data is a jump from 194.9 million to 301.4 million globally. Pharmacological treatments we have are currently we have our benzodiazepines, SSRIs, SNRIs, and older TCAs. Benzodiazepines are again associated with a lot of unwanted adverse effects, and geriatric patients may have a higher risk of falls and fractures. Etifoxine is an anxiolytic and a dual mechanism action on the GABAergic transmission. One of them is direct potentiation of the GABA receptor activation and the modulation of GABA receptor via stimulation of neurosteroidal production. Etifoxine is devoid of benzodiazepine related side effects such as sedation, amnesia, and tolerance and dependence. In healthy subjects, etifoxine showed no evidence of any deleterious effects on attention and alertness in comparison with lorazepam 2 mg. Now, a phase 3 study in Indian population of etifoxine versus alprazolam for the treatment of GAD with somatic symptoms showed that etifoxine 50 mg capsule was non-inferior in comparison to alprazolam 0.5 mg tablet overall. Both the treatments were well tolerated. Now, obviously, it is a new molecule, so we have to be careful in the use, and the research that we have is also very recent, and we need more research data to be fully confident of it. But currently, we have some research showing that etifoxine is a good molecule that can be considered clinically. Thank you.